Welcome back to Yale, and thank you for joining our conversation. What we're going to do is just lead a conversation about the Affordable Care Act and where we go from here. I think we'll start out chatting, but we also want to hear from you. We want this to be as interactive as we can. My name is Zack Cooper. I'm a faculty member here in the Department of Health Policy and Management, and then in our Department of Economics. I also run the Center for Healthcare Policy at Yale. And I'd say it's not an exaggeration to say that healthcare is probably the most important issue right now in the US domestic agenda. So healthcare is 17.6% of US GDP. It's a shocking number. 1 in every $6 the US spends goes to healthcare. And if we think about growth, the growth in healthcare spending, that's where the real issues are. So we see median household incomes that haven't increased in the US in 15 years. And the real reason that hasn't happened is because of rising healthcare costs. And the rub is, while we spend more than any other country on healthcare, it's not clear that we get more. So we've got life expectancy that lags behind Greece, infant mortality that's way too high. There's a lot of good in the US healthcare system, the amazing organizations, and we'll talk about our amazing organization here. But where do we go? And sort of cue up the Affordable Care Act. The most dramatic piece of social policy legislation in I think the last 50 years, certainly the biggest healthcare reform since the introduction of Medicare in 1965. It's a reform that changes the way Medicare pays for healthcare, that introduces some pretty wide-ranging changes to our insurance markets that we'll talk about. It hasn't been at all controversial. It's nothing, not too big a deal. The latest Gallup polling out 2 weeks ago, so 48% of Americans still don't approve of the law, 47% do. There have also been 62 attempts by Congress and the Senate to repeal the law. So I couldn't think of two better people, two better Yale alumni. I'm not a Yale alumni, I'm here for moral support, but two remarkable Yale alumni here to share in the conversation with me. Marna Borgstrom needs no introduction. She's a graduate of our School of Public Health. Right now she's the president and CEO of Yale-New Haven Hospital and the Yale-New Haven Health System. She joined it, I think, straight after your MPH as a management fellow. Took over the helm of the organization in 2005. It's a health system that's got $2 billion in revenue annually.
3.6.
Like I said, 3.6. 3.6. $1 billion here, $1 billion there. Eventually,
well, Yale-New Haven Hospital is $2 billion. So
okay, got that part.
Yeah.
I have 13,000 people employed in Connecticut. Is that
21,000?
21,000 people employed in Connecticut. I should let you introduce yourself. Right, yeah. It's growing. Right. Actually, it added a couple thousand last week, and then Harlan Krumholz, who also needs no introduction, who's the Hines Professor of Medicine here at Yale, and really one of the leading cardiologists in the nation, if not the world, but also one of the leading health services researchers. What blew me away is he's written 800 peer-review articles. Where do you find the time, man? and trying to not make me feel as bad about myself as you do. So let's just start by saying, Marna, how's the ACA affected Yale-New Haven? How's it affected you? Have you noticed it?
Well, we've noticed it, and actually we'll probably take you off if there's a script, because we can talk about the ACA, but you said something in your introduction that will bring me back to channeling my friend Betsy Bradley about what we spend money on and what we get for it. But I think in a nutshell, when the ACA was being developed, we very early on jumped on board and said, this is an imperfect idea, an imperfect piece of policy, but we need to move forward and we've got to start somewhere. And so we have always been a supporter of the concepts behind the Affordable Care Act, because I think that, for most of us who have been in some aspect of healthcare delivery, the thought of people not having coverage and therefore not feeling that they had access to care is a very troublesome concept. And I think that the Affordable Care Act has helped in certain ways to get some people access to insurance. But I would say that it's, we still have a long way to go because it's largely been insurance legislation rather than healthcare delivery. I don't think that it has been able to help deliver on the promise of enhancing access for a whole lot of reasons. But, I think that it was the right place to go at the right time.
Mm-hmm. What do you think? The ACA, we're about a year on from the full implementation. Are we the better for it?
Well, I don't think so. First, I just want to say Marna's an extraordinary leader, and that response of saying, we're behind it and we're going to figure out how to make it work is one of leadership, of saying, how are we going to make things better and how we're going to deal with the situation we have. I don't think there's any question that we're better off now than we were before. I always find it perplexing that the polls would say that half the people aren't for it. I think if you ask them what they're not for, they have trouble saying what they're not for. It has to do with the polarized political nature of our society and the idea of what Obamacare represents. Not actually what the content of it, but what it represents in the political sphere. And by being for Obamacare, you're for a party, you're for a president, you're for certain other policies, but you can't really understand exactly what it is. The legislation itself, to say it's incomplete, I think it's good for everyone to have a really good sense of this. It's not just saying that the legislation was unsuccessful in achieving sort of a mature vision of where the next part of healthcare should go, but it truly is incomplete. It wasn't done. The Senate passed, Obama made a decision that he couldn't bring the Republicans on. And so he goes to Baucus and says, we're going to go it alone. We're going to go it alone because otherwise we're going to get stuck. The Republicans are just not participating with us in a way that's going to help us create this legislation. They go energy first, and then health is going to go next. And so they make this fateful decision that they're going to go with no Republican votes and make this thing work. You can argue about whether that was wise, whether it was going to come back to bite him. It certainly wasn't going to help the country come together, but it wasn't clear that if he went the other way, you were ever going to get any health legislation. So the commitment was to say, we've got needs in this country that supersede the need for us to worry about partisan politics, and if they're not going to work with us, we need to make it happen. But then what happens is, finally, a lot of fighting. The House has got their ideas of what this bill should look like. Senate's got their idea of what the bill should look like. At the end of the day, finally, after a lot of wrangling and some special deals that were cut, surprise, Senate passes, and the House is working on it. And the reason they got the Senate to pass it, by the way, was because when Kennedy dies, it becomes a rallying cry that we need to do this in legacy to Ted Kennedy. So it sort of re-energizes the thing, gives it the final push. Senate passes. House has got their bill all lined up. They've been working on it like heck for such a long period of time. And then Scott Brown gets elected. Nobody expects Scott Brown to get elected. And what Scott Brown does is he kills a supermajority in the Senate, which means you can't bring a bill back to the Senate and repass it. So the way this works is Senate passes a bill, House passes a bill, they go into committee and they fight. And they know when they pass their bills, they're not done. They put stuff in the bills that they never expect to become law because they're going to be chits when they get together and negotiate. They don't worry about the details because then they know staff members are going to be up all night going through every word and fixing the final bill that will go to the House and Senate and they'll pass together. But in this case, surprise, Brown wins. Nobody expects that. They lose a supermajority, and now the House is told, you have to pass the Senate's bill or we won't get anything. And the Senate knows, even though they weren't done with the bill, that's what the bill is going to be in the end. So what you got was the process was truncated prematurely. And I do think that with more discussion, they would have funneled in more stakeholder views. This may not have been a long period in time before the final passage, but that's when all the activity occurs, all the horse trading, all the practical investment in is this thing going to work. It's when the lobbyists really rev up and start talking and saying what the consequences are. We think of lobbyists being bad, but they're actually also portraying what the issues are for the various stakeholders. All of that stuff didn't happen. So then the Affordable Care Act passes in about 900 and some pages, and it's got 10 titles in it. But the most important thing in this bill, at least two most important things in the bill from my perspective were the access and enrollment. So that's in the first two titles of this first two sections. And, you know, it attacks the issue that we've got a lot of uninsured in the country. It's bad for everybody to have uninsured in this country. It's bad for the uninsured when untoward things occur. It's bad for the hospitals in terms of lost revenue. It's bad for planning. They're outside the system. It's bad for everything. These people are in a very vulnerable position. And we've got, by the way, Medicaid covering people in very uneven ways all across the country. This says there should be a national standard for who's eligible for Medicaid. And the feds say we're going to step in and help make that possible. We'll support the states because they support a lot of the budget. And they also say individuals who want to get insurance are by themselves. They can't get insurance. They're victims of the market because they've got no negotiating power. And they said, what we're going to do is create these exchanges so that people can have purchasing power when they're going to buy insurance, so that you're not alone. You're with everyone else who needs to buy insurance, and we'll tier it. You buy, but we're going to say everyone's got to be in, because if everyone's not in, then the insurance doesn't work. It's going to be too expensive. So everyone's got to be in. Try to make it affordable, and you'll have the purchasing power of the group. And then, so access and enrollment. The other part was quality. I've already talked too much, but the issue is, it's hard not to be in favor of the fact that the states that came in have markedly lowered their unemployment rates. The Medicaid expansion has occurred, and in general, it seems like it's been successful in the states. Many other states pushing back, they've pushed away federal dollars, and they've had continually high uninsured rates. They've left people out. And then the exchanges, still have for all their issues, they've enrolled millions and millions of people and allowed them to take advantage of a community market advantage that they wouldn't have had otherwise. Now, the principal problem with it was implementation. I mean, there's lots of things the bill could have done better, but the implementation side was flawed, starting with healthcare.gov. But I think it's hard to argue that we're not better off having fewer uninsured, larger incentives for quality, and some efforts to try to reform the way in which care is delivered so that people can start focusing on health more than utilization. So anyway, that's a long answer, but that's, I think, where we are.
And I couldn't agree more. I mean, what I often say to my students is this actually isn't a particularly remarkable piece of legislation. And maybe you disagree. What I say is, if we took out the political hoopla and we closed our eyes and we just didn't listen to the news for 5 or 6 years, this actually isn't a really big deal. Like, what this basically did is it kept the system as it was, and it brought more people in. And it basically said to this group of folks who were self-employed and getting insurance from the small group market, we're going to fix that section. And we're not really going to touch the other folks out there with employer-sponsored insurance. We're going to sort of tinker around the edges on Medicare and try to improve the way we pay, but that's not grand reform. I think in many ways that's not the reform that's even necessary to fix the U.S. healthcare system. I think what happened is it got pulled into partisan politics and something that, to be very, very frank, was basically what was sketched out by Bush 1 as his health reform became, this sort of absolute caricature of what it really was.
But, can I just, stepping in, because, I sometimes wonder if Harlan is a physician or a policy wonk, because he is such an important presence in Washington, and I think in his role in an outgrowth of the legislation, the PCORI board has really advanced a lot of the focus on quality. But, I think that what we have to do, and the politics are very difficult, is not lose sight of the fact that we have to really enhance and move this legislation forward, because what it intended to do and what it's actually been able to do are not a complete picture yet. As an example, the state of Connecticut, was very proud of the fact that it was one of the first states to expand Medicaid eligibility. And what they did was they grew in a period of about 10 years the number of people insured in Medicaid from 350,000, 400,000 to 750,000. And what they did was they took their funding of that program for acute care and physician services down to essentially nothing. And they taxed the hospitals, and then they got a 2/3 federal match. And what happens is you've got providers, not just the hospitals, but physicians, who are being paid 40 cents on the dollar of cost. You don't even cover your variable expenses, let alone your fixed expenses. So you have a lot of providers saying, it's not that I don't value this, but I can't afford to provide the care because it's not being covered. And when we open the exchanges, again, Connecticut led the way in building a model for enrollment in the exchanges. What we have found is that fully a third of the people who went to enroll in the exchanges were eligible for Medicaid. So it's contributed to the growth of Medicaid rolls, and you have this incredible imbalance in terms of what is being used and what's being paid for. And I think that we all recognize that we need to evolve this to a system of paying for value rather than just people with the system. But we also have to recognize while we're making that transition, we have a lot of people hitting the system. And the fact that, you know, this is a federal law and there hasn't been an even way of leveling the playing field for access and service delivery across the states, you know, continues to make this an important work in progress.
So if I put you on the spot and I said one change, we have to introduce one change to the ACA to make it better. What's the change you would push for?
One change. You know, I think the biggest change that I would put forward is that we have to level the playing field in terms of defining what we want, who we're insuring, what we want them to have access to, and then what it takes to pay for that. Because there's a disconnect between policy and where we say we want to go and what we're actually putting in place to make that happen.
Harlan, what do you, if I put you on the spot and I said the one change we need to make?
Well, so there's a lot of changes around the edges that you could do, and there are a lot of changes that are occurring that are just occurring too slowly with regard to I think the transition to the way in which we're paying and our need for better quality measures and to be able to protect people and increase the transparency. You know what I'd like to see? It offends me that we pay less for certain people in our society on health care than others. And I think it sends a message that your life isn't as worthwhile. And that doesn't mean whether they have access or not, but the notion that we're paying 40 cents on the dollar for you and you're going to get a premium, you know, to me sends a message. And the way people are received within healthcare, you know, when you know you've got a call from someone who you're going to lose money on. I mean, let's be honest. People think about margins. They've got to pay salaries. They've got to stay in business. The hospital's big enough so that probably doesn't happen. But within office settings, you know, whether or not you're open to Medicaid patients, how you treat Medicaid patients, what the length of time is for Medicaid patients. Everyone knows that all these things play out in everyday thing. And it's a lack of respect. And, you know, there should be a minimum level that says, you know, this is what needs to be paid. Now, I understand 10 to 12 of the states have a third of their budget going for Medicaid. So you've got to figure out where the revenue side is going to come from. But to make it work by saying to people, you must care for, you're basically creating charity care without calling it charity care. And that creates a sense in the system that leads to unfairness. And we know what parts of the population are disproportionately bear this kind of burden. And when people in power, healthcare professionals, are looking at these people coming in who are having very inadequate ways of paying for the care through the government, it just sends, I think, messages, and I think it affects the quality of the care as well. And the business model for anyone is to figure out, how do I bring in high-margin people? How do I please them? How do I make them have a delightful experience? And actually, if I can be grumpy to the people who I'm actually losing money on in even subtle ways, it actually makes my bottom line better. Now, I'm not saying anyone's sitting there thinking at night, how can I do that? But in subconscious ways, it would be remiss for us to say humans wouldn't have that enter into their minds. Now, you know, if you say, we're going to double the excise tax on cigarettes, you know, things in our society that are not in people's best interest, that end up raising costs all the way around, and for which maybe they've been pulled in by advertisements and addicted to, and we can find ways to grieve revenue streams on things like that. Maybe we can defray some of the costs, but that was one of the things I thought that needed to be addressed. It's not just access and eligibility, but how can we ensure that they're being respected, honored, that their care, that people are being paid for their care in ways that are reasonable, because I think that it has reverberations throughout the entire healthcare system when you talk about equity. So I know this was going to be unpopular because when the bill was scored and when people talk about the cost, I go, well, how can you possibly pay more? But is it really a society that we want to have where somebody's coming in where everyone knows you're a money loser? You know, you're a money loser when you come in. And if you go somewhere else, better off for me. You know, that can't be the way that places run. And that's got, so if you ask me, you know, it wasn't something anyone touched, but it bothered me. It really bothered me. And maybe when we get to more population-based pricing, we can see that we're bundling large groups of people and we're bundling them all together for a certain amount, and we're not making a differentiation. And certain populations are more needy, and that'll push us to give better care to those groups because we're trying to reduce their healthcare costs, improve their outcomes, because they're ones ultimately who will break the bank if we're not proactive. And I, again, hate to put everything in business terms, but that's the way medicine runs. And there are dedicated people, healthcare professionals, leaders like Marna who are inspiring, but in the end of the day, she's got a lot of employees, she's got a lot of responsibilities. If she doesn't hit her bottom line, it's not going to work. The place is going to close. So she's got to figure out how it works. Business models have to be aligned with our values. And that's where we've got to make sure the government's helping us ensure that what we want as a society is aligned with the way in which payment occurs, which is pushing us towards a society we aspire to, not the society we have. So that's what I would like more thought about how the policy can help create that milieu.
Harlan and I, as usual, think quite similarly about these issues. You know, one of the things that I'm most proud of in our organizations, and I'll use, you know, Yale-New Haven Hospital, which at 1,500 beds is a behemoth, is that I believe that if you went into any patient care unit, if you went into the operating rooms, if you went into any of the clinic settings, the bed, the treatment bay, the whatever you see a patient in has nothing to do with their payer source. It is purely based on patient need, and that's been a value. That's, you know,
although that's not true in the outpatient area.
But it comes back to your. I mean, as a system, that's a value that I said core to our values, and I think that, you know, you're right. But you can have really, you know, important values like that, and you can't make the business model work. And the conversation that we've been having with business coalitions is, if you look at our business model and our health system, 1 out of every 4 patients cared for any place in our health system right now is insured by the state of Connecticut. And we're getting paid about 40 cents on the dollar of cost. So we're losing 60 cents on 25% of our patients. Medicare pays us about 88 cents on the dollar of cost, and Medicare throughout the system is about 37% of our patients. So you look at the vast majority of our patients, we do not get paid cost as the government defines cost for their care. So what happens, and has historically happened, is we cost shift to commercial payers, and depending on what those contracts are, who they're with, who you're insuring, it can be anywhere from 15% over cost to 150% of cost. The only populations that are fairly consistently having their health care managed now, and we do it with our own employees, we have put in place care coordination models for chronic asthmatics, for people with diabetes. These have been voluntary. We have a Know Your Numbers program, which incents employees and their dependents to take costs off of their health insurance spend if they participate in healthier behaviors. You know, GE does it, United Illuminating does it, the city of New Haven is doing it with their insured patients. And that's all good, and we actually have seen some incredible results. We went to having a goal of 50% fewer unnecessary visits to the emergency department for people with diabetic crisis in our employee group to 0. We didn't expect to go that fast, but it was just sort of getting involved, getting care managers in, working with our employees, and you can change behaviors. The problem is that we're changing behaviors and reducing utilization in a pay-for-volume system still on the only patients on whom we make money. So we're kind of doing the right thing and we're shooting ourselves in one foot while we're continuing to see the largest growth in our patient populations in those insured by the government, where we are being underpaid, where Medicare is once again looking at the number of people who are hitting Medicare eligibility and saying we don't have the money to pay for these people without bankrupting Medicare. And so while we're investing in the future in pay-for-performance and ACO models, you still have a lot of people who are older, who have had unhealthy behaviors, who are hitting the system and who want good traditional care right now. And I think the problem is that to solve this, we're going to need some working capital broadly in the system to be able to build some of the models so that we can get behaviors and changes in demand that are ultimately going to start to align with the goals that you have, that we have, that the Affordable Care Act had. But right now there's an imbalance, in the overused analogy. We got a foot on the dock and a foot on the boat in the boat. We want to go someplace, but we're stuck in a care and payment model that is a necessity, because today there were over 1,250 patients in beds at Yale-New Haven Hospital right now, and they really don't care about the Affordable Care Act. They only care that they're getting safe, high-quality care, that they're being respected, and they want what they need right now, while we're trying to figure out how to solve the problem for the future. And it's a very challenging balancing act right now. The other thing, just because I have the microphone, and I said I wanted to challenge our friend Betsy Bradley, who used to be in the School of Public Health. Betsy's done a lot of good work that also says when we look at how we perform against other developed countries, and you look at the spend on healthcare and outcomes, you're missing a big part of the equation, which is the investment in social infrastructure, so that it's more than healthcare. You can't just put it into healthcare and have the measure be certain healthcare outcomes. We have to look at, education, housing, things that, as a country, we have had much more uneven, shall we say, to be politically, balanced investments in. And when people aren't safe at home, when they can't eat, when they're not educated, you're going to get certain behaviors and lifestyles that are going to contribute to a potential overuse of the healthcare system.
Mm-hmm. And one area that I've talked to Harlan about, I think it's so easy when you have these debates to have them turn into abstractions, right? The privately insured or people on Medicaid. I think what strikes me in healthcare is if I went around the room and we were all at a cocktail party and I told some story about my family and the medical care my mom received, my father received, somebody would answer back about a story that they have about where the U.S. healthcare system failed them. And hospital-acquired infections end up being one of the leading causes of death in the United States. How do we tackle these quality issues, these issues that everybody faces in such an enormous sector of the economy? Is this an issue, Harlan?
Well, I think Marna's the one to answer this. Of course, locally, there's been a lot of activity. Yale's got resources, and they've put them into trying to make the place safer, and there's been a lot of attention to it. I've been a big proponent of transparency, and I think that it's the exposure of our performance that forces us to come to terms with what it is we're achieving and the results that are being accrued, and forcing us to find solutions. It's when they're not, we can't see them, we don't understand them, they're in the back of our minds, but we don't have any sort of quantitative estimates of what we're doing, and we can't track our improvement. So, I believe we published a paper last year that said in-hospital mortality across all conditions has dropped about 30% over the last decade. Hospitalization rates across all conditions, even at a time when we're putting together OBS units and other ways of keeping people in the hospital, even accounting for that, have dropped about 20%. And in mortality, readmissions after hospitalizations are also beginning to drop as well. So on the results side, I don't think there's any question that there's marked improvement. A lot of our quality measures are imperfect, but they seem to all be trending the right way. And the hospitals have never been safer than they are now. But no one feels like the job's done and that we don't have a long way to go. But I think that one of the great success stories of the last decade is the way in which everyone has embraced this notion that we may be doing harm that was unintended and unappreciated for many years. And that now that we can see it and we're starting to measure it and report it, it becomes a target for action and that there's been progress being made. But we're still, I mean, when you look on the wards, we're still practicing a lot like the 1950s. I'm talking about the doc side, you know, the way in which we practice, the way we're thinking. I mean, we don't train people to be thinking that, you know, if you don't wash your hands before you walk in a patient's room, you might as well walk in with a knife. I mean, we don't make it equivalent to the harm, the danger, you know, of the kind of way that you're creating a toxic environment, safety issues for patients. So we still approach it very casually. So as much as the hospital puts up on screensavers and as much as they make hand washing units and Purell dispensers available in every 5 feet in the hospital, there's still a cultural issue about saying, how can I make this a safe place? Why am I waking people up in the middle of the night? Why is there so much noise here? What kind of language am I using that instead of calming people down is getting them to be alarmed? I mean, why is this patient without 2 meals while they're waiting for a procedure, and so they're starving and they're malnourished while they're here? Why have I kept them in bed rest, and not allowed them to get strong for the time when they need to go home? Because it's more convenient for us, because when we do rounds, we know they'll be there. In fact, why on rounds do I not schedule the time when I'm going to see them during the day? So all day they're in a heightened sense of anxiety. When is a specialist going to come by to see me? The family's uncertain when it's going to happen. And everyone's sort of on edge that if I go to the bathroom or if I take a walk around, I might miss somebody important who's coming here to see me, so that I'm uncertain, as opposed to giving them a window. I mean, we do it at restaurants. Why can't we give them little beeper devices? If they want to walk around, starts beeping red, that means someone's in your room waiting to see you. We don't. Well, I think the advance is seeing through the patient's eyes and their experience and trying to understand, what does that feel like? And our culture has been about what my day is like, not what their day is like. And that's the switch on safety, that's the switch on experience, that's the switch on saying, it's not just goodbye when you leave the hospital, but their episode of whatever illness that is isn't over. And they've got to now deal with whatever else went on. So I think these are the things, I'm just talking about the medical profession now, that we have to deal with, that we've been far too permissive about. And as we've sat on a pedestal and been important and made sure everything revolved around our days, that's got to end. That's got to end. And when we become patients, our family members become patients, we're outraged. Mm-hmm. When we're running through our day, we can't see it. Mm-hmm. And so that's got to start from the training to the way in which everything's configured. And by the way, that we have to pay attention to the doctor's experience too, and nurses, that they have to be able to not be tethered to a monitor. No one wants to be staring at a monitor instead of the patient. But when you got to spend 3 hours at the end of the day doing paperwork, if you don't keep up during the day, that becomes a problem. So all of these issues about everyone's experience needs to be paid attention to. Then we need to find out what is it going to look like in 2020, not try to retrofit a culture of 1950 into an era where the world's flat, digital, and we have different expectations, and we honestly can do better than we ever did before.
Yeah, if you want to debate, Harlan and I probably aren't going to debate because we agree on so many things, but I think in the system what we have achieved, and it's an ongoing journey, is to become in the aerospace and manufacturing industry a high reliability organization, and that means taking 21,000 of our 21,000 employees through training and follow-up training and reinforcement in behaviors throughout the organization, taking 7,500 members of medical staff, some of them full-time faculty, some community-based, through high reliability training. And the concept behind it basically is everybody has to be 200% accountable. So, if a patient care associate sees a physician going to enter a patient's room and hasn't washed their hands, you have a responsibility to speak up. Every morning, Saturday, Sunday, every day of the week, we have a safety huddle across the system in every patient care area. They only last about 15 minutes. First question is, how long has it been since our last serious safety event? Everybody in the organization who wants to pipe into that knows that. Serious safety events are events that cause significant harm. Then we go through, are there safety concerns today? What are they? They could be, as simple as somebody's doing some flushing in the water system, and we want to be sure that people in a certain building are aware that there could be a backup in such and such an area, or they could be very significant issues. We go through best catch awards, safety catch awards. Did anything happen in the last 24 hours that was really remarkable? There are almost every day there are amazing safety catches. Some of the worst events that I've seen in our organization recently have been one-offs. We look at them and you say nothing that we had in place could have prevented this as it was. So what you've got to do is be able to deal with those openly and honestly, do root cause analyses, and this is iterative. We are never going to be there. It is a constant journey toward making care more predictable, more patient-focused, more evidence-based, and it is everybody's responsibility. And human behavior is such that when you got many different people with varying levels of education on different shifts and getting people to all focus on the same thing in the same way, is an extraordinary challenge in human behavior, but it has been demonstrated to have great impact on safety and quality in other fields, and that's where we're going to have to do. It's not magic, it's blocking and tackling, and it's operating with values.
So as an economist, I think about this as incentives, and I think the idea of the airline industry is a fascinating one, and why they've been so quick to adopt safety changes. And I think fundamentally it is an accountability issue. Mm-hmm. It's that if I, as the pilot, don't follow safety regs, I go down with the ship. Mm-hmm. Right? If we started cutting off doctors' hands if they didn't wash, if their patients got infections, right? The hand washing rate.
I've got a country for you to go to. Right? Very welcome.
No, but it's fundamentally an accountability issue.
Yeah.
And I think one of the challenges is how do we increase it? And with these bigger healthcare organizations where it's...
But not in a punitive way. You have to start with...
Fingers, not hands.
Right.
But you have to start trying to make it safe for people to do that and to move forward, and move to progressive levels of discipline and accountability. But, when we started reporting this, we saw our serious safety events rise extraordinarily. Remember?
Yeah, that's right. Yeah.
And everybody said, "Oh my gosh, are we getting worse?" And what you really realized was that people just weren't sharing the information before. And so then you get to a new baseline, you understand what's contributing to that, and then start moving. But you have to, the airline industry has proven that you have to be able to make it reasonable, safe, and blameless for people to start helping you get at systematic, problems.
Yeah, we should open it up. So we have some roving mics.
Uh-oh.
Yeah.
These are all for you, Marna.
Yeah.
I hope.
No, keep going.
David Liebschutz, class of 80, and a shout out to my classmate Harlan for a wonderful presentation. So, bumper sticker. Think globally, act locally. The healthcare system. A lot of you were talking about global changes, about incentivizing. Doctors generally think in terms of medicine by patient, not in terms of population, in terms of public health. Are the incentives mismatched for the medical students that you train, for the system that you manage at Yale-New Haven, and how do we align those incentives so that the doctor, the nurse, the healthcare professionals' incentives are aligned with the system?
Well, I'll just quickly say on our side, on the physician side, they're terribly misaligned, and the doctors in the university at this point are paid largely by relative value units, which creates intense competition among the doctors to grab relative value units, which is, for those in the audience, it's sort of the time the doctors spend has sort of been quantified in terms of what the contribution is, and it's skewed towards procedures. So you can do one procedure, and that would be like seeing 20 patients in the outpatient. So it pushes you to want to do procedures. It pushes you to want to see people rapidly. It pushes you away from things like teaching and teamwork. And it pushes you towards making sure you grab your relative value units, because at the end of the year, people come to you and say, you're at 1,000 and you're at 1,500, and people get ranked, and their compensation is all based on that. Instead of creating a milieu where we come together and create joint goals for the team, and the degree to which the team achieves those goals is the degree to which we all share in what that benefit should be, and that if there are people who aren't contributing well to that, the team itself has got to work that through, just like you would on any successful team, about whether people are playing their position right and whether they're helping people around them be better. But there's no consideration of that. It's all my individual RVUs if I'm a clinician, and it's driving people towards perverse behaviors that lead them not to necessarily think about the patient, but to think about their accumulation of RVUs, not outcomes, not quality. And I would push the most important thing in medicine today that we could teach is teamwork. It's not about us, but it's how well the team is. I may be amazing, but if I don't help everyone else around me be amazing, or if I'm not a good teammate, ensuring that everyone's communicating, collaborating, coordinating for the benefit of the patient, then we failed. I don't care how good a surgeon I am. If rehab doesn't work, or if the whole team doesn't work, we lose. And if we lose, we shouldn't be rewarded. We've got to get that mentality into medicine. It doesn't exist right now, and we're not paid like that. So for that reason, you've got to, I think, fix that. That's one piece to fix. There's other issues around the hospital compensation and other things that can be fixed, but that's a very important one that's a problem.
I would add to Harlan's bumper sticker, it's teamwork and communication, because that's been an issue. But what we've done in the health system is every employee, including the people who are burnishing the floors in the evening, have an incentive plan, and what they are incented to do and to perform to is the same stuff that I am incented to. There we're built off of the same incentive plan, and they are very specific measures of patient safety and quality, patient satisfaction, patient engagement, employee engagement, because if the employees aren't playing, then you're not going to get any of this done. And fourth is financial performance. But we all have the same line of sight, and it's not perfect, but it helps to create some alignment that didn't exist before.
It's much better, and annual reviews and specific and explicit goals, and of which part of them are how people work together. The hospital and health system has been much better than the university that way.
Yeah, so you want a question there back in the left. You can wherever you.
Hey, Adrian Thomas, class of '98, and full disclosure, I'm an orthopedic surgeon in private practice in New Hampshire, so I'm a little bit different than the academic world that you guys are in, but I came from an academic place. With regards to, I think of public health, I think of preventative medicine. I think of keeping people healthy, not treating the sick, almost, ironically. The question being is now everyone has insurance, but in a lot of states, people are still seeing an increased number of ER visits because there aren't enough primary care doctors out there. So my question is, what is the ACA or in general health care reform doing to create more primary care doctors so that people aren't using the ER still as their primary care doctor, because then they're only going for events, not going for preventative care. And I feel like if we increase the amount of preventative care we have, we can decrease overall costs.
I think the solution is pay orthopedic surgeons less and pay primary care more. and cardiologists less and primary care more.
Also, but in the end, I agree with you. Because you pay primary care more, but what's being done about it?
I mean, so the answer at the federal level is, at least coming out of their executive group, is I think they know that they haven't been focusing on it. In a sense, they've been focusing on the wiring for the last 5 years. And I think what they're trying to do is change the conversation now that the ACA is out there. I think you're starting to see it in benefits designs. And I think at least in terms of ER use, that's going to be the most effective strategy. It's something that I think Yale-New Haven is thinking about internally. I have to pay more if I go in direct via an ER than I do if I go to an urgent care clinic, right? And we ought to put a financial incentive to that so that the person has to make a choice.
So I have a different view on that. I think that, first of all, the ACA did have one of those sections, I talked about the 10 sections, was on workforce, but actually they never even populated the workforce. There was, because of the dissension, they never actually constituted that group. PCORI was one group, the workforce group was another. They never constituted. But I think, one, better use of non-physicians. Nurse practitioners are key and need to be part of this, and probably it needs to be a teamwork issue. And then the second thing is, I don't think anything wrong with the ED as an urgent care place, especially if it's not busy, that we can't charge ED rates if people are coming in and using it for that. But sometimes we have unused capacity in EDs for people who need things. People are already going to minute clinics and other places. I think about medicine, it's going to be, where do you need the relationships? And where is there a commodity in medicine that you just need? I just need my throat swabbed. And actually, I don't need more. And that's just my view, that there's some commodity services that could be created in very efficient ways. There are other areas where nurse practitioners and doctors need to have a relationship with you and are helping you through other things. And we need to be creative about how we're going to make that. I don't think the answer is going to be we're going to double the primary care docs.
But I think it's incentives. You know, I think the best analogy for me is, say, you know, eating, right? Like, imagine I didn't have to pay for the food I got and I wanted to get a quick lunch. There's nothing stopping me from going to the Union League Cafe, popping in, picking up a quick bite.
You live in Pearson. How much do you eat?
Yeah, fair enough. But what we want is
you give meals free.
We need people to have a stake in where they go. People make amazingly good choices, right, when they have the ability to choose, and there are sensible incentives in the system. And I think until, you know, if we always have it be the same price for going to an ER as going to a minute clinic, as going to an outpatient clinic, as going to an urgent care clinic, as going to primary care, people are going to use the most intense, most convenient option. And I think fundamentally it's a price story. And I think that's a benefit design. Yeah.
I'll speak loudly.
Please.
I'm a advisor, class of 78, and I'm not in the healthcare profession. So you started off the conversation basically saying, you know, how great the ACA, how it is, how it's improved things for everybody. And I've got to tell you that I listened to you, and most of your comments were about the perspective of people of the facilities, if you will. If you think about the healthcare system with providers, labs, and facilities, and if you think about people, you've got people in groups, and you've got people in individuals, and you have people who are uninsured. I'll grant you that the uninsured, more of them can have coverage nowadays. I won't speak about groups, but in terms of the individual market, which you started off the conversation about how the individual market has improved because basically people now have more buying power, if you will, I think that's diametrically opposed to what's really happened. In the individual marketplace, there are fewer choices available than before. In New York State, Oxford has essentially converted their individual plans over to basically an exchange-based plan. Aetna has dropped out. And the exchange-based plans have very limited networks. So if you think about most of the health care that people want, you know, you go to a provider or you go to a facility, I grant you everything you said about the facilities and what has to be improved there. But, you know, it's cheaper if I can go to a provider. And what the result of the ACA Act has been, for those of us who are forced into the individual marketplace, it's got very, very little choice and very, very narrow networks. So my question to you, and I do have a question after all of this, is basically, you know, if you can put aside the statement that says this was the best thing since sliced bread and all that, do you see any hope to address what are really fundamental? The ACA Act has made things worse for those of us who are in the individual marketplace than a few years ago. Do you have any thoughts as to how the individual marketplace can be improved, or basically, as far as you're concerned, it is improved, it is better?
Well, and by the way, to your point, United just threatened to drop out of some of the exchanges.
I said Oxford is United Healthcare.
Yeah, United. Yeah, you
remember?
Go ahead.
You know, one thing I would say, I think you're absolutely correct, but each state is different. So in Connecticut, the exchanges have really not narrowed networks at all, but they are very expensive. They are essentially catastrophic insurance. So people who go in as, you know, individuals into that market have very broad choice. In general, Anthem, you know, has largely, most of the payers have largely priced their premiums off of other commercially available products. But the problem is that for, you know, most people, as I said, the out-of-pocket upfront before they run through a deductible and copay is just horrifically expensive. And, you know, I think it comes back to, you know, and there are, so you guys are much smarter about this than I, but a big philosophy about how much state rights prevail, because the states have a very big role in the health insurance business, and they're all over the place, and the politics are very local and they're very parochial, and I think that they have not produced what was intended in large measure in that portion of the legislation.
I'm interested what Zack has to say. I just want to say I wasn't suggesting that the thing was nirvana, just that I thought it had advanced by putting more people under insurance. What do you think about what's going to improve the market?
So I think, so two things. So I think there is a fundamental tension between affordability and network size. And I think that's something that's going to play out over the next 10 or 15 years. And basically, if you want an affordable plan, I think the trade-off is you're going to have to sort of deal with a narrow network. And I think that's that's here to stay. I think what will fix the insurance markets, and it's something we've got to think about as these markets change, is competition in these insurance markets and how much competition there is. And in many ways, that's why I find some of the market changes that we're seeing, the mergers of, or proposed mergers of Aetna and Humana, Anthem and Cigna coming together. Because what we really want are these large firms competing against each other for our business. And when companies like United pull out, and when the number of choices in these exchanges goes down, it leads to precisely the results that you're talking about.
Hi, Ron Goldster, 75. I'm from Minnesota, where Mayo Clinic is located. First, I echo Mordecai's concerns about the individual market. My premiums are going up 50% this coming year. That's pretty big. But I'd like to go back to the first question, which had to do with your compensation method, the RVUs, and quality care teamwork. I wonder whether there's a piece of the chain that you have not addressed yet, and that is the relationship between the insurer and the provider in terms of the method of payment. Seems to me that even with the compensation method that you describe, which I believe Mayo Clinic also uses, the billing that comes out of the provider to the insurer is still fee for service. And if you're only getting paid 40 cents on the dollar for Medicaid fee for service and 88 cents or 82 cents on the dollar for Medicare fee for service, aren't we ultimately better off with a service that is outcome-based in terms of how reimbursement is done? And if that's true, what is the alternative? And for whatever alternative you choose, how do you get from here to there?
Yeah,
That's you, Carlan.
So I think everyone knows payment needs to change from fee for service to some level of capitation. And I think you described it, 1 foot on the boat, 1 on the dock. Right. It's going to happen, and I think the honest answer is nobody really knows quite how to get there. The argument that the administration is making is that Medicare is the biggest payer, and so if we can get them paying for quality, that'll create the airspace for the insurers to follow behind. I think what you'll see in these areas where, and this is actually the counter argument that the insurers will make for becoming bigger, is that the bigger they are, the more they'll have the heft to change the way they pay.
I think what you want to move away from is, so this RVU system is, it's counter to the best interest of the entire system.
Yes.
And the issue, I mean, you see things like, I have a friend who was at Duke who told me that at the upper levels of the leadership there, they would spend some part of the meeting figuring out whether or not the MRIs were running 24 hours a day. You know, what was keeping them from running 24 hours a day? Why wasn't the volume up? When I would start off, and I remember going into clinic and seeing a sign on the wall saying, "We have 2 spots open in the echo schedule today. Can anyone fill them?" You know, I'm in an academic practice. I'm on salary, but still there's this sense of needing to utilize the machinery and capacity that we have in order to maximize its potential. I'll put it like that in a polite way. You know, and so the issue, I think we'd be better off going to an outcomes-based way. And there's lots, the hips and knees now out of Medicare are going to be bundled to a large extent. So it's going to put an emphasis on the episode of care as the patient experiences it and the outcomes that the patients receive. We were part of, you know, our group developed the quality measures that are going to go along with that, which include pain and function and how people feel so that we can assess how successful the surgery was. Now, the issue is going to be make sure the case mix adjustment's right so that people don't refuse to do surgery in certain people because they think it's going to make them, they're harder surgeries and they make them look worse. So it's about getting that right, but I can see a movement in this direction which is going to incentivize us to work together, and it's going to incentivize us to produce results that are going to be transparent and for which we're going to be accountable and for which payment is going to be aligned. It's already happening. The Secretary of HHS has made a commitment that a high percentage of the care is going to be paid for in value. She's making a promise that we can't deliver on because we don't have the metrics to do it, but you can see us moving in that direction.
And I'll make one example, and I want to give you the final word. Readmissions are the perfect example. Harlan's the national leader in studying them. What is it, 1 in 5 Medicare patients get readmitted. There's a hospital in New York that has basically done a phenomenal job getting down readmissions. And even with the quality payments in their ACA, it's not profitable, right? Because in a sense, the readmissions that they're now avoiding also represent a loss in revenue. And until fundamentally you lose money doing the wrong thing, this won't work. And I guess the question is, how How are you preparing to make this transition? When do you see it happening?
I honestly can't answer that. So what we're doing organizationally is saying we have one overarching strategy for everybody, and that is to provide unparalleled value to the patients and families we serve. Value is defined as the quality, safety, patient experience divided by the cost price point. Because fundamentally, how quickly we change, how much we change, who changes, value is still going to be important under a better fee-for-service system or under a pay-for-value system. And so, we've got, I would say, pick a number, 90% of our, employees, physicians, everybody focused on how do you maximize value under the current system, because, they're coming to work every day. How do you make care better, safer, and more cost effective? And then we've got, sort of a skunk works and a much less than 10% of the organization focused on how do you deconstruct a population health model and then rebuild it, both understanding the insurance and financial risk components, but more important, having in place the connective tissue that allows you to not rely on just, and Harlan said it earlier, physicians' offices, the acute care setting, and traditional post-acute care, but really bring in everything from home care to digital medicine to everything else, because and then when you actually make the transition so that you've got 90% of the organization dealing with that and 10% dealing with legacy systems, I couldn't begin to predict that.
Well, there we go. We could keep having this conversation for hours. We are out of time. Well, I hope this is a conversation you continue out there. We're all happy to continue with you. We're delighted to see you here. Welcome back to campus, and thanks for coming to our panel.